So, a great question is what will I feel, hear, smell, and see during RLE, cataract, or ICL surgery? Um, so, I'll just walk you through the experience from, after having taken sedation, being dilated in the preoperative room, and then you're gonna, walk with my member into the operating room. We'll have you seated in a, you know, a beautiful mechanical chair that's robotic and automated, but just super comfortable. And so you'll have a seat, and then we'll get you situated, and then we'll start to recline you, get you in a comfortable position. The surgery is done with you lying down, but in a very comfortable way. So you're not like flat, but almost like the dentists, where you're sort of, although the dental chair is not that comfortable, but just a little bit more comfortable than you don't have to open your mouth or anything. Then my staff or myself will come and chat with you, but at the same time, we'll start to prepare for surgery. So my staff will start to, take out the instruments that are fresh from the sterilizers. She will be putting drapes over our instruments to create a sterile field. So you'll see a lot of movement around you, nothing alarming, and everyone moves very leisurely. And then myself or another one of my staff will start to position your head and get you comfortable, but also to optimize the surgical exposure, or get you into a position that would allow the surgeon, myself, to see well enough. And then we'll start to prep the eye. By prep the eye, we mean we're going to start to disinfect around the eye. This is done with betadine. It's a very strong disinfectant that's gentle on the eye, but it does sting a lot. So we'll numb your eye, and then we'll put the betadine onto the surface of your eye, and then we'll start to vigorously scrub your eyelashes. There's a lot of germs that can live around your eyelashes. So that's, in my opinion, the key to success for not having an infection is just really being meticulous about scrubbing the eyelashes. And then after scrubbing the eyelashes, we will start to put betadine all the way around your eye, because the surgical drape has a little aperture, and when we put that on, we want everything in that aperture to be killed off by the betadine. And so that's the next step, is we have this clear drape, and that clear drape has a little hole in the middle for the eye, and that gets put over your face. So that'll cover everything in your upper body, and then that'll get positioned and clamped into a device that's well above your chest. That way there's clearance and you can breathe normally. We certainly don't want that drape hanging out over your mouth or anything. It can feel a little claustrophobic. Then we do our timeouts, and we double check and triple check our plan for you, make sure we have the right lenses. We typically only have one lens in the room at any given time, to make absolutely sure we didn't, since we're doing bilaterals most of the time, that we don't have the left eye lens, and then they're almost never the same lens, particularly when we do custom multifocal vision, things like that. So that's what the timeouts are for, is just double, triple check, make sure everyone's on the same page. So you'll hear us talking, and then you'll probably, or before that, I'll have probably gowned up, and then you'll see that I'm in, blue. I usually double glove, so it takes me a little while to get ready. And at this time, my technician has already, laid out our instruments and primed all our equipment, ready to go. At this point, we'll put a little device into the eye that will open up the eye. So it just sits gently inside the eye, and then it stretches the eye open. It's called a speculum. Often you don't feel it, but some folks have smaller eyes, and our speculums, it's kind of a one size fits all, but smaller eyes, it can be a little more sensation, a little more stretch on the eye, obviously. So, I'll definitely warn you if you have a small eye. I'll tell you to take a deep breath, and then we'll, slowly open it up. And I do, need to be able to see your eye to do the surgery. So, but that's usually not a problem at all. Most people can tolerate the eye opening to, about the amount that I'm showing you right now is how much I need to be able to see to do the surgery. After that's done, then we move on to surgery. So typically I tell you you're going to feel two tickles. And this is when I'll be using the blades for the incision. They're just micro. There's a 1 millimeter blade and a 2 millimeter blade, and they're very small. And we make the two incisions for access to remove the lens, put in the other lens, and so certainly at this stage you're just giving me a blank stare straight ahead. And there'll be a big bright light ahead of you, and that's coming from the microscope. It's very bright so that we can see every detail inside the eye and not miss a thing. For most patients, that bright light is the most off-putting sensation in this whole process. It's very, very bright. But before I turn on, I usually tell patients to take a deep breath and to anticipate a very bright light. And it's okay to look away for a few seconds, but we do need you to look right at the bright light during the surgery. Not necessarily directly at it, but just in the general direction, not rolling your eyes back or looking down or sideways. That way we can see right into your eyes to do the work. And the ketamine in the MKO melt is supposed to help with that. It's supposed to help you tolerate that light better. Yes, so most people ask me what will I see during the surgery, and usually it's just that bright light and then shadows. Typically we operate on the iris plane, so I can't see my own iris, and you probably can't either. Everything there is very close to the nodal point where you can't focus the light that close inside your eye. So you would just see, light and dark. So you can see movement, shadows moving around, but you won't be able to see me, the instruments, and at the very early stages, very soon after we create the incisions, we'll have delivered numbing into the eye, so anesthetic called lidocaine into the eye and onto the surface of the eye. This should take away all pain sensation inside and outside of the eye. But you will feel pressure here and there, light pressure, and the instruments that keep the eye at a healthy pressure sometimes can feel like a little more than what you're used to. So do expect some pressure here and there. We'll certainly let you know the steps where we anticipate you'll feel a little pressure. Most people will tolerate just fine and tell me they didn't feel much at all. Let's see. There'll be some cold fluid flowing through your eye almost at all times. It's the balanced salt solution that keeps your eye healthy and inflated during the surgery, and creates a stable environment for us to operate. As for what will you see, what will you see? We cover that here. You'll hear talking. The team will talk as from just chatting with you to chatting with each other to do our timeouts. Most of the time you just hear me talking, and I'm talking directly to you and letting you know what step we're on, what to anticipate, how things are going, and I'm a pretty efficient surgeon. I usually do the surgery in about 5 minutes, so most patients are by the end of it or close to the end of it, I tell the patient, oh, we're just cleaning up the incisions, and they're like, oh, you got done already? So it is a very efficient and fast surgery. So, I think you'll be impressed. This is certainly much, much faster than the teeth cleaning and much more comfortable. And back to the hearing, there will be some noises coming from my machines. And the reason for the noises, there'll be like dings and buzzing and pitches of different tones. Think of it as sort of the way the machine, the anesthesia doctor's machine talks to them, and the anesthesiologist is usually, watching monitors, but they're also getting input on, heart rates and, and oxygen levels. So my machine is doing the same thing with me. It's telling me the energy that's being delivered. It's telling me the vacuum from the machine that's removing the tissue, the cataract, the energy being applied to the cataract, the pressure inside the eye, the inflow, outflow dynamics. So it's giving me a lot of information, and so don't be alarmed. Sometimes you'll hear the ding, ding, ding noises. I like to keep it up because my hearing from years of motorcycling is not as good as your hearing, most likely. So I actually need that noise to be a little higher, so I can be well aware of how things are going, and the pressures. And oftentimes I think I find it hard to hear my staff through their masks. So yeah, so everyone tries to, I think, talk a little louder around me. But yes, nothing out of the ordinary, but some of these dings and noises, they're all very normal. Every surgery, I expect to hear all of these noises, but they'll be new to you. But hopefully they don't throw you off and alarm you. And mine are going to be a little louder than other surgeons, just because my hearing's probably not as not as good as other folks. Yeah, and we talked, there shouldn't be any pain, some light pressure here and there, and we'll definitely let you know in advance. That's about it. And after surgery, your vision's going to be dark for about 5 minutes. That's because of the bright light that you're looking at. It desensitizes and basically tires out the rods and cones in your retina. Just like if I were to stare at a bright light for 5 minutes, a very bright light, if I look away, there's going to be a dark, negative image of whatever I was staring at, and that's the rods and cones in the retina. Sort of, they're tired, they're burnt out for a little while. They have to regenerate, and so give it 5 minutes, and it'll go back to the brightness and go back to normal. It's just the retina has a way to turn up and down its gain, just like in a camera. When it's too bright, it turns it all the way down. And then when you look away, it takes a little while for it to turn back up. So don't be alarmed. I've certainly, I warn you before we turn off the microscope light that you're going to have 5 minutes of dark, in the center of your vision. I did have a patient several years ago, a younger patient for RLE surgery, a young man, and he did his first eye with my colleague, who uses barely any light. I don't know how he sees. I certainly can't see what he's doing on the computer screen from the camera feed. It's just he operates in darkness. And then I did his other eye, and I have, I think, normal amount of light that most surgeons use to see well. It's very bright, and he didn't have this with the no light in the first eye. I think he recovered very quickly, but then he had the dark spot for 5 minutes. But he made me very well aware of the difference between the two surgeons, and but I choose to be able to see that's we don't compromise on that. That's a safety thing. I don't have the special eyes of another surgeon who's able to see in the dark. So anyways, I think we've covered everything. We'll do another video about what to expect the night of surgery. So we'll just end here. Thank you very much.